Here's something that might surprise you. Even with all the amazing success stories in vascular surgery, using grafts to save lives and limbs, well, it turns out a small number of patients, maybe 1 to 4%, can run into a pretty significant problem years down the line.
Yeah, that's a really critical point. These late complications, they're called anastomotic aneurysms. They aren't super common, thankfully, but they're definitely serious enough that we need to talk about them.
Okay, anastomotic aneurysms. Sounds a bit technical, but basically we're talking about weak spots, right? Weak spots that can form where that artificial graft, the tube, is sewn onto your own artery, the connection point, the anastomosis.
That's a good way to put it. Like, think of a garden hose connected to a faucet. If that connection gets weak over time, you might see a bulge, maybe a leak starting.
Ah, okay. And you mentioned these are often false aneurysms. What does that mean exactly? It's not like the artery wall itself is ballooning out.
Right, exactly. Most of the time, it's not the whole artery wall stretching. Yeah. It's more like a small leak happens right at the suture line where it's sewn together, blood escapes, but it gets kind of walled off by scar tissue. So you end up with this contained blood collection, a pseudoaneurysm, held in by fibrous tissue, not actual artery layers.
So the main problem is the connection failing, not the artery itself just getting weak in that spot.
Precisely. It's that suture line disruption that's often the key event.
Yeah.
But whether it's that pseudoaneurysm scenario, which is more common, or more gradual weakening right at the joint, the bottom line is if these aren't spotted and dealt with, they can cause some really serious health issues.
Absolutely. And, even if you listening haven't had this kind of surgery or aren't expecting to, I think understanding these long-term possibilities really highlights how intricate vascular surgery is and how vital that careful long-term follow-up becomes.
It definitely gives you a deeper appreciation for the whole process, the surgery and the aftercare.
For sure. Now, to really get into the weeds on this, we've been looking at some chapters specifically on anastomotic aneurysms from a pretty comprehensive vascular surgery textbook.
Yeah, it's given us a really solid base to understand all the details.
Exactly. So our mission today in this deep dive is to unpack what these things are, why they happen, like what are the key factors, where they tend to pop up most often in the body, how doctors usually find them, and crucially, what can be done about them. And we'll try to keep it clear, engaging, and, avoid drowning you in medical jargon.
Sounds like a good plan.
Yeah.
So we know they're mostly these false aneurysms stemming from that connection point weakening. Let's talk about how common they actually are and where they tend to show up.
Okay, so the textbook says overall, maybe 1% to 4% of all these arterial connections, these anastomoses, end up having this complication. And this seems really important, that number doesn't tell the whole story, does it? It really depends on where the graft was put in.
That's absolutely right. Location, 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 you could say. It matters hugely. And it turns out the femoral artery, that's the main artery down in your groin, that's the most common spot by far.
Really? How common are we talking?
Well, the numbers vary a bit in different studies, but the range cited is anywhere from like 0.5% all the way up to potentially 24% of reconstructions in the femoral artery.
Wow, 24%. That's a massive range. Why the femoral artery? What makes it so vulnerable?
It's likely a mix of things. It's relatively superficial, so maybe more mechanical stress from just moving your leg. Plus, the underlying artery disease, atherosclerosis, can keep progressing right next to the graft, weakening that native artery tissue over time.
Okay, that makes sense.
There was one study mentioned, Van Aneker, that looked specifically at surgery for blockages in the aorta and iliac arteries. They found the rate of these aneurysms per connection site was about 4.8% in the aorta, maybe 6.3% in the iliac arteries in the pelvis, but then it jumped to 14% in the femoral arteries.
14%, so like 3 times the risk compared to the aorta in that study. That's significant. Did they look at how quickly these developed too?
They did, and what's interesting is they calculated the freedom from formation at 15 years. So 15 years out, 92% of the aortic connections were fine, 84% of the iliac ones, but only 76% of the femoral ones.
So a quarter of the femoral connections in that group had developed this issue by 15 years.
Essentially, yes.
Mm.
It really highlights that that femoral site seems to carry a much higher risk.
Okay, that paints a pretty clear picture for the femoral artery. What about the bigger arteries then, the aorta itself and the iliac arteries in the pelvis? You said the rates were lower there initially?
Yeah, the big studies looking at standard abdominal aortic aneurysm repairs often report lower rates, maybe in the 1.3% to 3.0% range cumulatively. But the textbook makes a good point that this might be an underestimate.
An underestimate. Why? Because they're harder to find deep inside.
That's part of it, yeah. They're deeper, might not cause symptoms early on. And also, how often people get follow-up scans can really vary. If you're not looking routinely with imaging, you might miss them for a long time. Some studies that did use regular CT or MRI follow-up suggest the actual rate could be, well, closer to 10%, maybe even heading towards 36% at 15 years if you model it out.
36%, that's a huge difference from the 1 to 3%. So basically, if you actively look for them with scans, you find a lot more.
It certainly seems that way. It suggests surveillance protocols might be really important.
What about other places like the carotid artery in the neck? Is it a problem there too?
Well, the good news is, after a really common procedure called carotid endarterectomy, where they clean out plaque, the risk of an anastomotic aneurysm is very low, maybe 0.3%.
Oh, that's reassuring.
But if the original surgery was to fix an existing aneurysm in the carotid artery itself, then the risk of developing an anastomotic one later is much, much higher. We're talking maybe 13% to even over 50% in some series.
Okay, that figures. If the vessel was already prone to ballooning out, the connection point might be weaker too. Now, timing. When do these usually show up? You said it's a late complication.
Generally, yes. Nowadays, we typically see them presenting, on average, maybe around 6 years after the initial graft surgery. Though it's important to remember, if there's an infection involved, that can speed things up quite a bit.
6 years on average. Does it matter why the person had the graft in the first place? Like, for a blockage versus for an existing aneurysm?
Yeah, it seems to. The textbook points out that if the original surgery was for blockages like aortic occlusive disease, the anastomotic aneurysms tend to show up even later, maybe 16 years on average. But if the surgery was for an existing aortic aneurysm, they tend to appear sooner, maybe around 9 years.
Interesting. So different underlying reasons for surgery might mean different timelines for this complication.
It suggests maybe slightly different mechanisms or contributing factors are at play depending on the initial disease.
Okay, so we've got a handle on what they are, roughly how common, where they pop up, and when. Let's get to the really crucial bit. Why? Why do they actually happen? What's going wrong at that connection?
Right. So as we touched on, the sort of central event is usually some kind of failure or disruption right at the suture line where the graft is sewn to the artery.
The stitches give way, basically.
In essence, yes. When that connection weakens, blood starts to leak out under pressure. It forms this pulsating blob of blood, a hematoma, and the body tries to contain it by forming that fibrous scar tissue capsule around it. That's your pseudoaneurysm.
So the body's attempt to fix the leak actually creates the aneurysm sac?
Kind of, yeah. And there are a whole bunch of factors, mostly local, right there at the surgery site, that can contribute to that initial weakening. One big one is actually the patient's own artery wall degrading over time.
The native artery itself? How does that play a role?
Well, remember, many people need these grafts because of atherosclerosis, hardening of the arteries. That disease process doesn't just stop. It can keep progressing in the artery right next to where the graft is attached. So the artery wall itself can become weaker, less structurally sound, right at that critical connection point.
Ah.
There's a study, SCORTUS, that looked at tissue samples from these sites. They found fewer elastic fibers, the stretchy bits, and the smooth muscle cells were replaced by more brittle fibrous tissue. So the artery just isn't as strong or flexible there anymore.
So the artery itself can be part of the problem. What about the things holding it together? The stitches, the sutures? Have they been an issue?
Oh, definitely. Historically, yes. Early on, surgeons used silk sutures.
Silk, like for clothes?
Well, surgical silk, but yeah, it's a natural material, and the body can actually break it down and absorb it over time. Not ideal for holding an artery together long term.
No.
So once they realized that, they moved to synthetics, like polyethylene and nylon. But unfortunately, those also had problems. They could lose their strength over years, eventually just fraying or breaking, linked to late aneurysm formation too.
Okay, so what's the standard now? Surely sutures have gotten better.
Oh, absolutely. Big improvements. The go-to for many surgeons now is monofilament polypropylene. You might know the brand name Prolene. It came out in the late 60s. It's much more inert, doesn't react much with tissue, less likely to cause clots or infection, and crucially, it keeps its strength really well over the long haul. Minimal degradation.
So Prolene solved the suture problem. Mostly.
Mostly, but it's not perfect. Polypropylene can still sometimes fray or even fracture, especially if it gets nicked or handled roughly with instruments during the surgery. Some surgeons actually prefer a different material, PTFE suture polytetrafluoroethylene. It feels smoother, maybe even more inert, but the trade-off is it's only about half as strong as Prolene at the same size.
Interesting. Are there ways to connect vessels without stitches at all, like staples or clips?
People have definitely experimented with that. Rings, staples, clips, even special glues. The idea is maybe less tissue reaction, maybe it's quicker or easier. Right now, vascular clips seem okay in some situations, but none of these non-suture methods have really taken off for major vessel connections. We just don't have enough solid long-term data on how they hold up, especially regarding this risk of anastomotic aneurysms. Sutures are still the standard.
Gotcha. Okay, so we've got the artery wall, the sutures. What about the graft material itself? Does the artificial tube contribute?
Well, modern grafts, usually made of Dacron, which is a polyester, or PTFE, are generally really durable. They don't tend to fall apart.
Hmm.
But they can still play a role indirectly. Some types, especially the knitted polyester ones, can stretch out a tiny bit. Over many years, they dilate.
They get wider.
Yeah, just slightly.
Oh,
And that slight widening, plus the fact that the graft is usually much stiffer than the natural artery that's called compliance mismatch, puts extra stress right on the joint on that suture line.
right, like connecting a stiff metal pipe to a flexible rubber hose. The connection point takes all the strain.
Exactly that. So even if the graft material itself is fine, its physical properties, how it behaves mechanically, can contribute to the stress at the anastomosis.
Okay. What about infection or inflammation? Are they big players here?
Huge players, yeah. Any kind of significant inflammation around the graft site, especially early on, can weaken things. That could be a reaction to the graft material, or maybe a blood collection, a hematoma that formed after surgery. And certain inflammatory diseases the patient might have, like Beset disease, can also increase the risk.
And actual infection, like bacteria getting in?
Absolutely. Obvious graft infections are a major cause, often leading to aneurysm formation relatively quickly. But what's really interesting, and maybe a bit unsettling, is that even when there's no outward sign of infection, no fever, no redness, nothing, studies have found bacteria hiding out in the graft material removed from these anastomotic aneurysms quite often.
Really? Like low-grade simmering infections?
Kind of. The most common culprit seems to be a type called coagulous negative staph. But other bacteria like strep, other staph species, even anaerobes have been found. So yeah, even a subtle low-level bacterial presence might be enough to degrade the connection over time. Wow. That's, yeah, quite something. And I guess technical slip-ups during the original surgery could also be a factor. Definitely. Meticulous technique is absolutely paramount. You need to take good bites of healthy artery wall with each stitch, especially if you've just cleaned out plaque with an endarterectomy. You can't put too much tension on the graft. You need to handle the sutures gently so you don't weaken them. Using the right size and strength of suture for the job, it all matters.
It sounds incredibly precise. You also mentioned mechanical stress earlier.
Right. Beyond just the compliance mismatch, the constant pounding of blood pressure puts stress on that joint. There's something called Laplace's law. Basically, it means the tension in the wall increases as the radius gets bigger.
So if the graft stretches out even a little bit,
Exactly. If it dilates, the tension on the suture line and the nearby artery goes up significantly. Think of blowing up a balloon. The bigger it gets, the more stretched the rubber is. It's the same idea. That's actually why surgeons often use little strips of felt material to reinforce the suture line, especially on the aorta, to help spread out those forces.
and does the angle of the connection matter? Like how the graft meets the artery?
It can, yeah.
Mm.
Fluid dynamics comes into play. A sharper angle can create more turbulence and uneven stress on the suture line. Ideally, you want the connection to be as smooth and straight as possible. That's why an end-to-end connection, where the graft connects directly to the cut end of the artery, is often preferred from a flow perspective over an end-to-side one, where it joins the side of the artery, if technically possible.
Okay, smoother flow, less stress. Makes sense. We've covered a lot of local factors right at the site. What about things related to the patient's overall health? Systemic factors.
Good point. Yeah, things like smoking, high blood pressure, high cholesterol, they all damage arteries everywhere, including at the anastomosis, potentially making it weaker over time. Being on blood thinners, anticoagulants, while often necessary, could maybe contribute if it leads to a hematoma forming around the graft site early on.
And certain diseases.
Yes, systemic inflammatory conditions that affect blood vessels like Beset disease or Takayasu arteritis are known risks. Also, some connective tissue disorders, like Ehlers-Danlos syndrome type IV, which affects collagen and makes tissues weaker, can predispose people to this. The risk in Behçet disease in particular can be really high, maybe 30 to 50% in some reports.
Wow, that's a very strong link.
Yeah.
So it really sounds like a combination of local stuff at the connection point and the person's overall health picture.
Precisely. It's rarely just one single thing. It's usually a mix of these factors coming together over time that leads to the problem.
Which I guess means prevention involves both super careful surgery and managing those general health risks afterwards.
Exactly right. The surgeon needs to be meticulous, avoid too much tension, get good bites of tissue, handle everything gently. Choosing an end-to-end anastomosis when possible helps. Using the right-size graft to match the artery. Strict sterile technique. Antibiotics before surgery to prevent an infection. All crucial. But, even doing everything perfectly, these can still sometimes happen, which just highlights why keeping an eye on things afterwards, surveillance, is so important.
Okay, so how are they usually found? Because it sounds like they can be silent for years.
That's often the case, yeah. Many, probably most, are found incidentally. Someone's having a scan for something totally different, maybe a checkup, and, oh, look, there's a bulge near that old graft site.
But they can cause symptoms eventually. What might someone notice?
It really depends on where it is. If it's in the femoral artery, down in the groin, because it's closer to the surface, a doctor might feel it during an exam. It might feel like a pulsating lump or mass, maybe a bit tender.
A pulsating lump, okay.
That big study by Demarche found about 2/3 of femoral ones just presented as that an asymptomatic mass. But others caused real problems. Sudden lack of blood flow to the leg, a painful mass, even bleeding.
Bleeding sounds terrifying.
It is. Other issues they saw were tiny clots going down to the foot, legs swelling, the graft itself clotting off completely, or the aneurysm pressing on nearby nerves or veins, and about 7% had signs of infection too.
So quite a range of presentations for the femoral ones. What about the deeper ones? Aorta, iliac arteries in the abdomen. Harder to spot.
Definitely harder to feel unless they get really big, especially if someone's overweight. Often they need imaging to be diagnosed. If they cause symptoms, it might be vague stuff like feeling a pulse in the belly or some abdominal or back pain. But they can also present dramatically rupture, infection, clots breaking off, or even eroding into nearby organs like the bowel.
Yikes. Given how serious those complications sound and how hard they are to detect just by feel, it seems odd there aren't clearer rules about regular scans after aortic surgery.
It is a bit surprising, yeah. Practice varies quite a bit on routine imaging follow-up for aortic and iliac grafts.
And the carotid ones in the neck, what about them?
They also often enlarge quietly. They're rarely felt.
Huh.
Problems usually arise if they start pressing on things nearby, like nerves, or if they start shedding little clots that go up to the brain, causing TIAs, mini-strokes, or even a full stroke. Rupture is pretty rare, thankfully, maybe only 3% of cases.
Okay, so if a doctor suspects one or finds one by accident, what's the next step? What imaging do they use to get a proper look?
Nowadays, the main tools are ultrasound, CT scans with contrast, that's CTA, CT angiography, and MRI scans with contrast, MRA. The pictures from modern CTA and MRA are usually so good, so detailed, that the old-fashioned method, sticking a catheter right into the artery and injecting dye, called arteriography, often isn't needed just for diagnosis anymore.
And arteriography might not even show the full size anyway.
Right, because if there's clot lining the inside of the aneurysm sac, the dye only shows the channel where blood is flowing, not the true outer wall, so it can underestimate the size.
Makes sense. So CTA and MRA are generally the way to go. Did any studies compare how well these different scans work?
There was one older study by Bastunis that looked at ultrasound, CT, MRI, and angiography for aortic ones. They found all of them were pretty sensitive, meaning good at picking them up if they were there. But MRI and CT seemed a bit better at correctly ruling them out if they weren't there.
Yeah.
Better specificity. MRI came out on top in that study for overall accuracy. But, that was a small study, and the technology for all these scans has improved a lot since then.
So basically, ultrasound, CTA, MRA, they're all useful tools, and the choice probably depends on the situation.
Pretty much, yeah. Depends on the location, what specific information the surgeon needs, patient factors like kidney function or metal implants.
Now, what if you find one, say, in the groin? Should you look elsewhere? Can people have them in multiple spots?
Absolutely. That's a really important point. Finding one, especially in the femoral artery, should definitely trigger imaging of the other graft sites. Because having them in multiple places, synchronous aneurysms, isn't rare at all. Maybe up to 1/3 of patients with one might have another somewhere else. And there's also overlap between aortic and femoral ones. About 13% of people with an aortic one also have a femoral one.
So finding one means you really need to do a full survey.
You really do.
Yeah.
Don't assume it's isolated.
And if infection is suspected as the cause, are there specific tests for that?
Well, blood tests looking for inflammation markers like ESR or CRP might be elevated, suggesting something's going on systemically. And sometimes a special nuclear medicine scan, a labeled white blood cell scan, can help show if there's increased immune activity concentrated around the aneurysm, which would point towards infection.
Okay, so we know how they're found. The big question then, what do you do about them? What are the treatment options?
Right. The decision on if and how to treat really hinges on several things. How big is it? Where is it? Is it causing symptoms? And what do we think caused it especially? Is infection likely involved?
Okay, let's take the femoral ones first. Do they always need fixing?
Not necessarily immediately if they're small and asymptomatic. Some might say observation is okay until they reach maybe 2 or 2.5 centimeters. But we don't have great data on rupture risk based purely on size for these specific aneurysms, so there's definitely a judgment call involved. If it pops up really soon after the original surgery, though, that's more worrying, might suggest infection, and usually prompts earlier action.
Hmm.
And of course, if it causes serious problems like bleeding or blocking flow, that's an emergency repair.
What about the deeper ones, aorta and iliac? Treated more aggressively.
Generally, yes, because they're harder to monitor reliably long-term, and the consequences of rupture are so dire, many specialists feel they should probably be repaired once found. Though, again, some argue for being selective, weighing the risks of surgery against the aneurysm risk for that specific patient. If you don't repair immediately, you absolutely need very close follow-up with regular scans. Oh, and if they're saccular, sort of like an irregular outpouching rather than a smooth widening, those are thought to be higher risk and usually aren't watched.
And the carotid ones in the neck.
Given the risk of stroke, they usually warrant strong consideration for repair once detected, and definitely urgent intervention if infection is suspected there.
So it sounds like symptoms, location, and size are key drivers, with a lower threshold for fixing the deeper or potentially riskier ones. What are the actual repair methods?
Well, a key principle is always suspect infection until proven otherwise. Infected ones are a whole different ballgame, much higher risk, often need complex reconstructions. If it's not thought to be infected and you're doing an open surgery repair, the goals are standard. Get control of the blood vessels above and below, protect any important side branches, and then either replace the weak section or somehow exclude the aneurysm sac. But doing surgery in a scarred area from a previous operation can be tricky, more bleeding risk, harder dissection. You also have to be careful not to knock any clot loose from inside the aneurysm during the surgery.
Open surgery sounds challenging. You mentioned endovascular repairs becoming more common, going through the arteries.
Yes, increasingly so, especially for the aorta and iliac arteries. Using catheters and stent grafts delivered from the inside avoids that big open operation, avoids clamping high up on the aorta sometimes. And with newer devices, fenestrated ones with holes for kidney arteries, branched ones for other vessels, we can treat more complex anatomy less invasively. It's often the preferred approach now if the anatomy is suitable. It can even be an option in some urgent cases, like a contained rupture.
Okay, so let's break that down a bit. First, open repair. If it's just the stitches that failed.
If it looks like a simple suture line disruption, especially if it happened early, sometimes just resuturing it might be possible. But more often, especially if the artery wall itself is weak or the old graft is deteriorating, you need to put in a new piece of graft, an interposition graft. That usually holds up well long term.
And for the femoral artery, open repair specifically.
You need good pictures beforehand, usually an arteriogram, to plan where to make incisions and control the vessels. You find the old graft, control it, then carefully dissect out the arteries below the aneurysm, the superficial and deep femoral. Give blood thinners, clamp the vessels, open the aneurysm sac, check carefully for any sign of infection, take samples. If it looks clean, you sew in a new piece of graft, maybe PTFE material. End-to-end connection is often preferred if possible. Sometimes if it was a big false aneurysm that disrupted tissues, you might use a nearby muscle flap to cover the repair, help it heal, reduce infection risk.
Quite involved. What about open repair for the aorta?
Again, detailed imaging beforehand is key check for infection signs, plan clamp placement, see how close it is to the kidney arteries. You can approach it from the side, retroperitoneal, or through the belly, transperitoneal. Often need to clamp above the kidney arteries. The usual fix is an aorto-aortic bypass, so a new tube graft from healthy aorta above to the old graft below. Sometimes you need a more complex graft, maybe with branches or extending down to the legs. If infection is found, it's a major problem, might need to remove the whole infected graft and reroute blood flow completely differently, maybe using the patient's own veins or arteries if possible.
And iliac artery open repair, similar idea.
Pretty similar principles to aortic, often done via that retroperitoneal approach. A key challenge can be preserving blood flow to the pelvis via the internal iliac artery. Might need a separate bypass for that. And you have to be really careful not to injure the ureter, the tube from the kidney, especially if the aneurysm is large or inflamed.
Lastly, open repair for the carotid.
Traditional approach is open surgery. Cut out the aneurysm, then either put in a patch to widen the artery, or more commonly, sew in a short interposition graft, maybe a piece of vein or synthetic material. If infection suspected, using the patient's own leg vein, saphenous vein, is usually preferred as it resists infection better. Tying off the carotid completely is really a last resort, very high stroke risk.
Okay, so open surgery remains a major option, but clearly complex. How does endovascular stack up? You said it's less invasive.
Yes, definitely less invasive for aortic and iliac ones. You avoid the big incision, potentially less stress on the body, maybe faster recovery. You use stent grafts, basically fabric tubes supported by a metal mesh scaffold delivered through catheters, usually inserted via the femoral arteries in the groin.
What kinds of stent grafts are used?
Various types, simple tubes or bifurcated ones that split like a pair of trousers to go down both iliac arteries, or uni-leg ones going down just one leg, requiring a separate bypass to the other leg. And for aneurysms right up near the kidney or intestinal arteries, we now have those specialized fenestrated or branched grafts.
What's involved in planning an endovascular aortic repair?
You need really high-quality CTA scans for precise measurements. The key is having good landing zones, healthy sections of artery above and below the aneurysm where the stent graft can seal tightly. You look at the diameter, length, angulation, amount of calcium in those zones. If the neck, the bit above the aneurysm, isn't long enough or healthy enough, a standard stent graft might not seal properly.
So you need a good spot to anchor it.
Exactly. Sometimes we use grafts with little hooks or bare stents at the top for better fixation, maybe anchoring just below the kidney arteries. And you always oversize right. If the anatomy isn't suitable for a graft going down both legs, you might put one down just one iliac artery. Then you need to do a surgical bypass, the fem-fem bypass, connecting the femoral artery on the stented side to the femoral artery on the other side to get blood flow there. Often with these repairs, you might need to intentionally block off one of the internal iliac arteries to get a seal.
Blocking an artery, doesn't that cause problems?
It can sometimes, yeah.
Yeah.
Risk of buttock pain when walking, or rarely more serious issues. So surgeons try hard to preserve at least one internal iliac if possible. If one has to be covered, often they'll plug it with coils beforehand to try and encourage collateral blood flow development.
You mentioned fenestrated and branched grafts for tricky locations near kidney arteries. How do they work?
They're pretty amazing, often custom made for the patient. They have little holes, fenestrations, or actual side tubes, branches, built into the main graft fabric, positioned exactly where the kidney or intestinal arteries come off. You deploy the main graft, then carefully guide smaller stents or stent grafts through these holes or branches into the target arteries to maintain flow while sealing off the aneurysm.
Wow, that sounds incredibly complex.
It is technically demanding, yeah. But studies are showing good results, especially for patients who are too high risk for open surgery. We still need more long-term data, but it's a major advance. Hybrid repairs, combining some open surgery maybe to prepare vessels with endovascular techniques are another option. But again, you absolutely have to rule out infection before putting any endovascular device in.
What about endovascular for femoral or carotid? Is that happening too?
For femoral, open repair is still mostly standard because of the hip movement potentially damaging stents. But endo has been done in selected high-risk patients. For carotid, endovascular is definitely emerging. Stent grafts, sometimes combined with coils, can avoid that difficult neck dissection and nerve injury risk. Early results seem promising, maybe lower immediate risks than open surgery, but again, long-term durability data is still limited.
So it really is a rapidly evolving field, with endovascular techniques offering less invasive options for many situations, but open surgery is still very much needed, especially for complex cases or suspected infection.
And that sums it up really well. It's about choosing the right tool for the right patient and the specific problem, weighing all the pros and cons.
And what about the outcomes? How well do patients generally do after these repairs?
Well, overall, repairing an anastomotic aneurysm tends to carry higher risks, more complications, higher mortality than doing the first aneurysm repair. That's partly because it's a reoperation in a scarred area, and partly because these patients are often older and may have more health problems by the time this develops.
What kind of numbers are we talking about for open repair?
For open repair of non-infected aortic ones, one study reported mortality around 4.5% for elective cases, but jumping to 24% for emergency repairs due to rupture. And overall complications could be over 50%.
24% mortality for emergency repair? That's high. What if it ruptures?
Rupture is catastrophic.
Yeah.
Just like a primary aneurysm rupture, the mortality rate for a ruptured anastomotic aneurysm is grim, often cited as 67% to basically 100%.
Wow.
It really hammers home why elective repair, fixing it before it ruptures, is so critical if it's feasible. Outcomes are vastly better when it's planned versus an emergency.
How do the endovascular outcomes compare? Better.
Generally, yes, especially in the short to medium term. Endovascular repair for aortic and iliac ones usually has high technical success rates and lower immediate complication and mortality rates compared to open surgery. Studies show good exclusion of the aneurysm over several years in most patients, without major leaks or needing conversion to open surgery.
What about the femoral ones? You said recurrence can happen even after open repair.
Yes, even with a better technique of using an interposition graft, recurrence rates over time are still reported in the range of, say, 9.5% to maybe 19%. Things like the graft dilating more, the artery wall continuing to weaken, wound problems, maybe being female seem to be risk factors, and redoing surgery for a recurrent one is even riskier than the first repair.
Okay, so clearly a complex problem with significant risks, but with evolving treatment options. The textbook even had a flow chart, right, to help decide treatment.
Yeah, it includes a helpful algorithm. It basically walks you through the initial assessment. Is it causing symptoms? Where is it located peripheral, aorta, iliac? Are there obvious signs of infection? That helps guide the next steps and workup in deciding on the best treatment path.
Right. Well, we've covered a lot of ground today, a really deep dive into anastomotic aneurysms. Just to quickly recap the big points. Their potential late complication after graft surgery, mostly false aneurysms at the suture line. The femoral artery is a hot spot. Multiple factors contribute local issues like artery wall weakness or sutures, plus systemic health factors. Imaging is key for diagnosis. And treatment involves weighing open surgery versus endovascular options, depending on many factors.
That's a great summary of a pretty complex topic.
So here's something to maybe leave you thinking about. As these endovascular techniques just keep getting better and more refined, how do you think the long-term game plan for managing and watching these anastomotic aneurysms might change? What role could even smarter imaging or more personalized risk prediction play down the road in tackling this sometimes challenging complication?
That's the million-dollar question, isn't it? The trend is definitely towards less invasive options when safe and effective. But getting that robust long-term data on durability and outcomes is absolutely crucial to really shape future guidelines for both treatment and how closely we need to watch these patients afterwards.
Absolutely. Well, if this deep dive has sparked your interest, or if it's relevant to you or someone you know, definitely dig into the source material, or more importantly, talk to your doctors for personalized advice. Understanding these kinds of complexities, I think, just makes us all better advocates for our own health. Thanks so much for joining us for this exploration.